Hello, everybody. I'm sort of bundled up here because we're going to get the polar vortex here, but not in a day or not for another couple days. But it is snowing outside in Ohio, so I use this as my excuse to be all bundled up. I hope any of you who are in the Midwest, particularly Wisconsin and Minnesota, are safe and hopefully not experiencing any difficulties with your heating. So without further ado, tonight we're going to discuss diagnosing hyper and hypocortisolism. And one of the most common questions that our internal medicine service gets on consultations from referring veterinarians is, here is this animal I think may have Cushing's disease or Addison's disease, but not all the signs are perfectly lining up, and so I'm not quite sure what test to start with, or I did this test and here are the results, and they seem kind of gray area. What should I do? What should the next step be? Is this really, hyperadrenal or not? So I will use the phrases Addison's and Cushing's, and hyper and hypocortisolism and hyperadrenocorticism and hypoadrenocorticism sort of interchangeably for, Addison's meaning hypocortisol and hypoadrenocorticism, and Cushing's disease meaning hypercortisolism and hyperadrenocorticism. So I apologize if it's a little confusing. I will do my best to stick to one, but I just want you to know that in case I say something that I mess up, I use three terms for each of the two diseases, and I will make sure if anybody has any questions, please put them in the chat, and we will address them at the end of our little conversation. So just to review the hypothalamic pituitary adrenal axis, we have the hypothalamus, which is stimulated by either low plasma cortisol levels, hypoglycemia, fever, and then any of a number of other stress hormone conditions that will trigger release of corticotrophin releasing hormone, or CRH. CRH is then stimulatory to the anterior pituitary and tells it to release ACTH, or corticotrophin. And then that tells the adrenal gland to release cortisol, and converts angiotensin to aldosterone. So you have both release of mineralocorticoid and release of cortisol. And then that cortisol release actually has a negative feedback effect on both the pituitary and the hypothalamus, as well as a local negative feedback onto the adrenal glands. And this is so that once a stressful event occurs or there's activation of the axis, just as with most of our endocrine systems, the system doesn't just keep going over and over and over again. You actually are able to put the brakes on so that the system is not forever turned on, and so we actually are able to turn it back down, preferably after the stimulatory event has occurred and is gone. So the pathophysiology of hypercortisolism is sort of seen. Frame A shows us what normally should occur when we have cortisol produced and our negative feedback on the hypothalamus and the pituitary. And then situation B is where we have a microadenoma in the pituitary, and that leads to an excessive secretion of ACTH independent of CRF release and independent of stimulus from an outside stimulating factor like hypoglycemia or stress. And what that does is it leads to constant stimulation of the adrenals. So the adrenal cortex becomes hyperplastic. It's almost like the adrenal cortex has been working out and suddenly has a lot of muscle and a lot of ability to release cortisol. So the cortisol released is increased, and that then in turn has negative feedback onto the pituitary and the hypothalamus. However, given the amount of cortisol released, because there is a microadenoma or even potentially a macroadenoma, a larger tumor of the pituitary, that release of cortisol does not negatively turn off the adenomatous tumor in the pituitary gland, because it's a tumor and so it really doesn't care about the cortisol's negative feedback. So that's where we have pituitary dependent hypercortisolism, or PDH. In frame C, we can see that there's a tumor on the adrenal cortex, which releases cortisol independent of any other signals. And that cortisol negatively feeds back to the other adrenal gland. And that other adrenal gland then begins to atrophy its cortex from reduction of production. But we also have negative feedback on the pituitary and the hypothalamus, so we have low ACTH levels and pretty much very little corticotropin releasing factor released. The effects on the body, most of us are probably pretty aware of these. We get increased protein breakdown and muscle wasting. We have increased fat synthesis, hyperlipidemia occurs, and we get central obesity and deposition of lipid within the liver as well. The muscle wasting that we see actually contributes to the abdominal sort of potbelly appearance we get in our patients because the abdominal muscles begin to weaken quite a bit. And with the addition of central fat occurring and the increased lipid in the liver starts to expand. We also get glycogen deposition in the liver. And as the liver expands and gets larger, especially with those weakening abdominal muscles, that really gives us that pot-bellied appearance that we see in our patients. There's also interference with antidiuretic hormone or ADH, and that's really the primary reason that steroids, whether endogenous or exogenous, leads to polyuria and polydipsia that's so classic with these cases. There's also a decreased thyroid level because cortisol will decrease production of T4. And there, like I said, there's increased hepatic glycogen deposition. As I mentioned, this causes hepatomegaly. It increases the alkaline phosphatase in two ways. It stimulates the cortisone, in dogs at least, it stimulates the cortisol isoenzyme of alphos. And then there's also a mild increase of ALT and a mild increase of ALP because of the swelling of those hepatocytes interferes with the movement of bile within the bile canaliculi intrahepatically, and that leads to some mild cholestasis. And then the cortisol itself will, and the swelling of those hepatocytes will lead to a small amount of ALT release. So we do get a more significant alphos release, but there is usually some mild ALT release as well. So pituitary dependent hypercortisolism looks a little bit different than adrenal dependent. The pituitary cases, about 75 to 80% of them are an adenoma in the anterior lobe of the pituitary. This leads to an impaired response to glucocorticoid negative feedback, and it usually suppresses with high dose dexamethasone suppression test. So remember, the HDDST, the high dose suppression test, is meant to be used as a differentiating test to determine whether you have an adrenal tumor or pituitary origin of Cushing's disease. It does not say yes or no, does the animal have the disease? It just tells you once you've determined the animal has the disease, if it's adrenal or pituitary. Why do we care? Because if it's adrenal, there is a potential for surgical removal of the mass and cure of the disease process. And for people who live near a location where the hypophyselectomy is done, surgical removal of a pituitary tumor can also be performed. 20 to 25% of pituitary cases actually have an adenoma in the pars intermedia, which is a narrow space in the pituitary. And those cases actually do not suppress with high dose dex suppression test often. They look like an adrenal tumor when we test them. So this will make more sense when we start talking about the specific test results. They tend to be larger than those in the anterior lobe, and they can be very confusing. So you can get a test result where you're trying to determine is there a pituitary tumor or an adrenal tumor. And with one type of result, you can say it's definitely a pituitary tumor, it's definitely not adrenal. And then with another type of result, you can actually say, well, it's either adrenal or pituitary. The pituitaries can be small. They're often microadenomas. Or large, which are macroadenomas. Macroadenomas often are accompanied by other clinical signs such as head pressing, dullness, and other things associated with having a brain tumor. The microadenomas are usually so small that they don't actually cause any compression or pathology of the rest of the brain, but the macroadenomas can get quite large and will start leading to changes in other neurologic functioning. Increased ACTH secretion from these tumors leads to increased secretion of cortisol from the adrenal cortex. And it may lead to atrophy of the other, or sorry, I apologize, may lead to bilateral hypertrophy of the both adrenal glands. Not always, and it usually has to be going on for a while before that happens. But as I mentioned, it's almost like it's the adrenal cortices are pumping iron because they have so much ACTH coming in, causing hypertrophy of the cortex. Adrenal tumors are usually an adenoma or an adenocarcinoma of one of the glands. Rarely we will see adrenal glands that have where each adrenal gland has a tumor, and oftentimes one of those is benign and not actually secreting any cortisol, and one is. It's an independent secretion of cortisol. The ACTH levels in those cases are usually low because you've got negative feedback suppression of the pituitary secretion of ACTH. In this case, cortisol levels are not suppressed by a high-dose dexamethasone suppression test because the adrenal tumors are much more robust at secreting cortisol than adrenal glands that are simply overstimulated by a lot of ACTH coming from a pituitary tumor. This is one of the reasons that we can use the high-dose dex test to differentiate between the two. The adrenal glands, in this case, the adrenal tumor is kind of like a honey badger. It doesn't care. It doesn't care how much how much dexamethasone you give it. It is not going to stop secreting cortisol. And the contralateral adrenal gland is often normal or small with an atrophied cortex. As most of us know, these cushingoid dogs are usually middle-aged to older. It's rare to have them younger than 6 years old. We see it much more commonly in small dogs, although we can see it in large breeds. Um, Poodles, Dachshunds, Terriers, Beagles, German Shepherds are some of the breeds we see it more commonly in. And larger breeds may be more likely to have an adrenal tumor than a small breed. However, overall, pituitary tumors are the most common in all breeds. Clinical signs, PUPD is present in 85% of these dogs, and polyphagia is present in 90% of them. So those are really the hallmarks. And clients don't always come in for polyphagia, but they're going to come in to see you when their dog is getting them up in the middle of the night and didn't used to, or pees on the floor because he doesn't get allowed out often enough. A very important thing when getting a history for a dog who the owners claim is urinating or having accidents in the house is to make sure that it's polyuria and polydipsia. So the animal should be conscious of the urination. It shouldn't be incontinence necessarily. The animal should actually drink more water and have larger volumes of urine. And that can sometimes be difficult with clients who don't do a lot of observing of their pet or may mistake polacuria for polyuria, that sort of thing. So I'm just going to make a comment that it's very important, as urology is one of my strong interests, to make sure that we get a good urination history and tease out, are we dealing with polyuria? Are we dealing with polacuria? Are we dealing with incontinence? Or are we dealing with conscious urination? Those are all really important things to suss out when getting a history from this owner. Otherwise, it's going to lead you down the wrong diagnostic pathway. These dogs are often lethargic, panting. They may have skin issues like pyoderma and alopecia, thinning of the skin, weakness, obesity, the hepatomegaly, and potbelly appearance. They may have hyperpigmentation of the skin and exophthalmos. Calcinosis cutis and dermatitis can actually be a real tough thing to determine because calcinosis cutis can take on many different forms, but most commonly it looks like plaques on the skin that are rather firm, almost like a hard scab. And they may or may not be itchy, but if we radiograph the animal, frequently you can see a bit of mineral deposition on the skin in those areas. Many of these classic signs, however, the textbook pictures that we all sort of saw in vet school are seen less frequently now that we're diagnosing these guys earlier. 25 years ago, we saw a lot more of these dogs come in just looking awful because not as many dogs lived inside all the time. Dogs may have slept in a garage or in a doghouse outside. Given the change in, at least in American and North American culture, in how we view our pets, many more of these animals are starting to sleep inside, even on the bed, getting the owners up in the middle of the night, and the owners are much more aware of what their urination habits are. These dogs are usually not sick in the conventional form, in that there's usually not vomiting, diarrhea, Eating is usually not a problem for them. They're not coughing, they're not sneezing, they don't have pain, except that, maybe their age may lead to some mild osteoarthritis, but honestly, all of their endogenous cortisol is probably helping things a bit in that sense. They don't necessarily have liver disease other than the alk phos elevation and a mild ALT elevation, and they often don't have renal disease. So if you have any of these clinical signs in a dog with PUPD, it should sort of lower the index of suspicion of hyperadrenocoricism. It does not remove the suspicion, but it kind of lowers it on your list of differentials. You want to be looking for other things first before testing for hypercortisolism. Blood work, as I mentioned, most of them, 95% of them, have high alk phos. The alk phos level, though, does not appear to correlate with the severity of the disease, and that's an important thing to remember. 85% have hypocystinuria, basically fits with the PUPD. 50% may have a low T4, and that's basically a SICU thyroid low T4. 75% have high cholesterol. Up to 30% may have a low phosphorus, and that is most likely because of the panting. When dogs pant a lot, they blow off CO2, and that is an acid. And so they make themselves respiratorily alkalotic. And in respiratory alkalosis, the body dumps phosphorus a little bit. So they may have a low phosphorus. There's about like four things that cause a low phosphorus, and that would be one of them. Refeeding syndrome is another. They might have a mild hyperglycemia. They might have a mildly low potassium and a mildly high sodium. Nothing that's going to really trigger you to worry too much about. And they generally have a stress leukogram, meaning a low lymphocyte count, maybe a mature neutrophilia, a monocytosis, and eosinopenia. The alk phos catalyzes hydrolysis of phosphate esters. And there, as you remember, there are three serum isoenzymes that we look at in the dog. There are actually several others, but these three are the big ones. The liver, origin one, which is secondary to cholestasis, and that is generally intrahepatic cholestasis, so sludging of bile within the bile canaliculi, the microscopic ducts, or the just slightly larger aspects of the biliary tree that are within the liver before it drains to the common bile duct. There is a bone isoenzyme from osteoblasts, and that is generally seen the cause of elevation of alk phos in young growing animals. Rarely we will see it in animals with significant neoplasia of the bone, but primarily it's in young growing animals, and then our corticosteroid induced one. The corticosteroid induced alkaline phosphatase, if you work with a lab that measures it, the elevation of the CALP is sensitive in the fact that if an animal has hypercortisolism, you will see an elevation of the ALP. But it's not specific in that there are several other reasons why the CALP may be elevated. Many things can make it go up, but the majority of cushingoid dogs have a CALP elevation. We see vascular hepatopathy in these dogs. We see it because of glycogen and lipid deposition within the liver, within the hepatocytes, secondary to the hypercortisolism. We can actually see a disease process or a pathologic process called vascular hepatopathy in some older dogs that have no evidence of adrenal illness. And if we biopsy those livers, they are consistent with steroid hepatopathy, but they don't necessarily have the other signs like polyuria and polydipsia or polyphagia. They have a normal ACTH stim and a normal low-dose dexamethasone suppression test. So there is this other syndrome that will cause an alk phos elevation. You take an aspirate of the liver, it looks like a cushingoid liver, but you don't have other evidence of steroid or adrenal-based illness. And so that's an important thing to remember if you see an older dog with an alk phos elevation who otherwise does not appear to be cushingoid. So that is just something to keep in mind. If you diagnose a dog with vascular hepatopathy, it generally does not require any sort of treatment unless the animal is hyperlipidemic and has a high cortisol, or I'm sorry, has a high cholesterol or a high triglyceride, in which putting it on a low-fat diet is the first step in treatment. So let's talk about our testing options. You've got your patient that comes in, it's PUPD, it's polyphagic, it has an elevated alkaline phosphatase, and you're concerned this dog may have hypoadrenal or hypercortisolism. We have a urine cortisol creatinine ratio, or UCCR. This it can be a very useful test, but it's usually best used when you have a dog who may be PUPD only and you think there may be another cause and you just want to rule out Cushing's disease. You don't really think they have it, so you'd like to just rule it out. We have the low dose dexamethasone suppression test, or LDDST, for diagnosis, and then we have the ACTH stimulation test. For differentiation, once we've diagnosed hypercortisolism, for differentiating, as I mentioned before, between PDH or adrenal tumor, we have the high-dose dexamethasone suppression test, with the exception of those 20% or 25% of pars intermedia adenomas, which will look like adrenal tumors in the way they test. We also have imaging. So the tests are great, but we oftentimes will try to pair them with imaging if we have it available. So ultrasound is a really good option, especially since many of us have either a referral center locally where we can send a patient in for an ultrasound, or a traveling ultrasonographer will come to the practice and do an ultrasound. Or if you're lucky enough to have somebody in your practice who is very skilled at adrenal ultrasonography, which can take quite a bit of practice, I will admit to be able to do. But we can also do dynamic CT and MRI for people that have that available to them to look at the adrenal glands. Are they both plump? Is one big with a tumor on it, or one have a tumor on it, and the other maybe is normal or a little bit small? That's another way to get a piece of information that's going to help us support our decision of whether it's pituitary or adrenal dependent. We could also, in theory, look at the ACTH level, which obviously, if it's high, we're thinking it's a pituitary dependent disease process, or if it's low, it's an adrenal dependent process because you have all that negative feedback to the pituitary. In the past, we've not really run this test very often because ACTH is incredibly volatile. So unless you actually worked at an institution that had the availability of the test, of which there were maybe two or three, you weren't actually going to test an ACTH level because the act of drawing it, letting it sit around for however long till it got picked up by your FedEx service, shipping it overnight, oftentimes it would degrade even within a few hours, and you end up with unuseful information. So when we look at urine cortisol creatinine ratios, the sensitivity is 75 to 100%, and the specificity is 22 to 77%, depending on which study you read. So based on this, it is very sensitive, which means that if your animal has Cushing's disease, it is highly likely it's going to be positive. But there are other things that can make it go up. Any sort of stress or non-pituitary or non-adrenal disease will also potentially make the urine cortisol creatinine ratio go up. So it's not very specific to Cushing's disease, but it will detect almost all of them. So what we do is we take a first morning urine sample when the dog is relaxed, meaning the dog has been at home, there's been no stressful recent events. So you don't have you don't take it at work. You don't, meaning you don't take it when the dog is there at your practice for a visit, because just coming into the practice is probably stressful for the dog, even if it's a good stress. You don't take it when the dog has been boarding. You don't take it when the dog has recently been to daycare. You don't take it when they've recently been groomed or traveled. You want a boring week for the dog, and then the owner gets it first morning urine sample after the dog has been sleeping, and that's going to be the best test. It can be taken as a free catch. It doesn't have to be taken as cysto. The owner can just catch it, put it in a clean container, and bring it in. It doesn't have to be sterile. It can sit around. Cortisol is in itself a very stable hormone. So the owner can throw it in the fridge and drop it off the next day, even if necessary. But like I mentioned, it's easily increased by stress or concurrent disease. So what we do is we use this test if we're trying to just rule it out. We don't think the animal really has Cushing's disease. We're just trying to cross it off our list. So that's when you would want to do it if you don't really think the dog has it. If the test is positive and there's an elevated cortisol creatinine ratio, it does not diagnose the disease. It just means you can't take it off the list. And then we have our ACTH stimulation test. Now, this is very handy because it's a 1 hour test, so it doesn't require the dog to be at your practice for all day. Um, it requires one or two cortisol samples, and for people who have who have corticin available to them, then it is quite convenient to use. And essentially, it is stimulating those pumped up adrenal glands to try to release a lot of cortisol. So like I mentioned, those adrenal glands have been going to the gym because of all that ACTH that they've got. So you can actually force it to release even more. So just like a strong person, they can actually lift more weight than you expect them to. The ACTH stimulation test has a sensitivity of about 85% as well as a specificity of 85%. So it's a pretty decent test. It can also be used to diagnose iatrogenic Cushing syndrome. So if you have a dog who's on a lot of steroids, whether it's because you've prescribed them for the animal for whatever disease process they have, or the owner's giving them a lot of topical steroids or something, and the dog develops PUPD, and you're not sure if it's actually the Cushing syndrome that's causing that or it's something else, you can use this to tell whether or not the adrenal glands have been basically overcome by the exogenous steroids you're giving them. Because what you'll get is a flat response. It won't be zero the way an Addisonian case is, or low. It will be normal or on the high end, but your pre and your post level will be the same pretty much because you've suppressed your adrenal glands to the point where they're not doing anything. It's just whatever dose of steroid you gave them. And so that's not going to change during that hour. When you have adrenal tumors, you can have variable results. So this is not the best test to do if you suspect an adrenal tumor. You may miss up to half or even a little more than half of adrenal tumor dogs with an ACTH stim test, and you may be in the gray area or you may have a falsely normal test. Low-dose dexamethasone suppression tests have a sensitivity of 95% and a specificity of 73%. Their sensitivity being higher means that most cushingoid patients are going to have a positive low-dose dex suppression test. But you may have some patients that will have a positive low-dose dex suppression test that don't actually have Cushing's disease. So it's more specific than the urine cortisol creatinine ratio, but not quite as specific as an ACTH stimulation test. If suppression occurs at 4 hours, so this is one where it's an 8 hour test, so you take a cortisol sample at 0 hours, you give them a low dose of IV dexamethasone or DexSP, then you take a 4 hour cortisol sample and an 8 hour cortisol sample. Normally, we would expect either the animal suppresses at both 4 hours and 8 hours, and that would indicate a normal test. So that does not support Cushing's disease. But if the animal suppresses at 4 hours and then escapes, meaning it goes back up at 8 hours, then pituitary dependent hyperadrenocorticism is likely. Like I mentioned, adrenal tumors don't suppress at all with this test. You will have a straight 0, 4, 8, and they will be flat across the top. It will be high cortisol level, high cortisol level, high cortisol level. Not high, but it's going to be the same level across the top. Now, one exception is that if you don't have suppression like that, you might have one of those pars intermedia tumors. So that's why it's either PDH or adrenal tumor if you have no suppression at 4 or 8 hours. High dose dex suppression tests are used to differentiate between adrenal and pituitary because adrenal tumors could not care less how much dexamethasone you give them. You're going to get a straight across the top, 0, 4, and 8 hours. This test is run the same as a low dose dex, except the dose of dexamethasone you give is higher. And you can use, by the way, either dexamethasone or DexSP for this test. When you're running a high dose dex suppression test, 29 out of 30, 96% of adrenal tumors do not suppress. So can be confident if you don't suppress, it could be an adrenal tumor. If you have suppression, then it is, if you have suppression at 4 hours and 8 hours, you already know the animal has Cushing's disease. So that tells you it's pituitary. If you have suppression at 4 hours and escape at 8 hours, it's still pituitary. Okay? So it is not for use in diagnosing hyperadrenal cortisolism or Cushing's disease, but it's to differentiate between PDH and adrenal tumor. Okay. There are other tests like the plasma ACTH level, as I mentioned, that is a volatile compound. It does help you differentiate between an adrenal tumor and a pituitary tumor. It's elevated with pituitary tumors usually, and it's low with adrenal tumors. But like I mentioned, it rapidly degrades in vitro, so it's difficult to get an accurate measurement if you have to send it out to a lab. If you do send it out to a lab, you need to check with that lab about handling and shipping and timeline and how accurately you think you'll get your result. We now have the potential to perform eACTHs in-house with a Truforma platform. So Zomedica has produced the bulk acoustic wave platform of Truforma. It can be used to test a number of different hormones. My clinic uses it a lot for looking at T4 and thyroid stimulating hormone, TSH, especially in predicting hypothyroidism post I-131 treatment in cats. That's another talk we can talk about sometime, but it also has the ability to test ACTH. And the nice thing is you don't have to worry about all that degradation issue because you're literally drawing the blood and within 10 minutes you're running it on the machine. And it gives a very accurate result. And so you do have the ability to avoid all this high dose dex suppression, the imaging, that sort of thing, and go straight to an eACTH. If you have this platform, it allows you to differentiate between pituitary and adrenal and give a better idea of how easy it is to control that animal and whether or not surgical management may be worth doing. So, how do you choose which test you're going to use? Because that's really one of the challenges we have. So, we base it on the index of suspicion. That's whether we're going to use a urine cortisol creatinine versus one of our cortisol level tests. The signalment of the animal, how likely are they to have the disease? If this is a 3-year-old dog, I am probably going to use a urine cortisol creatinine. We rarely see Cushing's in dogs that young, unless it's iatrogenic because they're being given exogenous steroids. So, if I don't really think this animal has Cushing's disease and I think they're PUPD for another reason, I'll do the urine cortisol creatinine. What about clinical signs? Maybe you just have an elevated alk phos and no other clinical signs. Again, starting with the urine cortisol creatinine is not a bad idea to at least say, yes, I think they may have it and I need to go to the next step, or no, I can just rule it out and move on to looking for other causes of an alk phos elevation. Um, and then what is your availability of DexSP and Cortrosyn? DexSP, I'm sure, is pretty ubiquitous in most of our practices. Cortrosyn, Cortrosyn is the trade name, Corsyntropin is the drug. It is a synthetic ACTH. It's not inexpensive, and so some practices don't actually carry it. The nice thing is if you do buy a bottle of it, you can aliquot it out into 5 microgram doses, and it is given as part of the ACTH stim as a 5 microgram per kilogram of body weight IV injection. So it doesn't mean you're going to use a whole bottle on one patient the way we used to do it 20 years ago. We actually can use smaller doses and they freeze for up to 2 years. So if you do want to carry Cortrosyn in your practice, you can buy a bottle, aliquot it out into smaller amounts, and freeze it, and it will last for a couple of years for your ability to go ahead and use it and make it worth the cost of the expenditure. Now, certainly, if you have several patients, if you have a lot of patients in your practice who have the potential to get Cushing's disease, let's say you have a very large miniature poodle population, a very large Bichon population. Those are dogs who love to get Cushing's disease. Might be helpful to keep some Cortrosyn on hand. And then convenience. An ACTH stimulation is a 1-hour test. A low-dose dexamethasone suppression test is an 8-hour test, which means the dog drops off at your practice at the beginning of the day. They're going to be there for a full 8 hours, and they're going to be one of your last patients you send home at the end of the day. So really, there's a convenience issue. If it's a very anxious dog or a dog who's very aggressive, I'm not sure I really want them to hang out in my practice all day. So all of those things need to be taken into consideration. Clients may not like leaving their dog all day, that sort of thing. As I mentioned, index of suspicion is really helpful. And if there's a potential for the animal to have a non-adrenal illness that's making them look cushingoid, if the more severe that non-adrenal illness is, the higher the likelihood of a false positive result on testing. And what this means is that if you have a dog with an elevated alk phos, or you have a dog come in with polyuria and polydipsia, you have to think about what the likelihood of a non-adrenal illness. If the dog also is PUPD and it also has been losing weight and it also may have an elevated creatinine, its creatinine is 3.5, that may potentially lead to a false positive if you're going to do an ACTH stim or a low dose DEX. And so, because the animal has other underlying stressful events going on, so it may be useful to start with a urine cortisol creatinine ratio, or it may be useful to let the owner know that you might have to do both an ACTH and a low dose DEX, or you may do one and then you may get a gray area response and you may need to prep the owner for, well, we might need to do some imaging of the adrenal glands to see for multiple pieces of information that we're going to pull in to try and determine which of this animal's health problems is leading to the clinical signs we're seeing. And as we all are very aware, managing clients' expectations is really, really important when we're trying to get them on board for the testing that we need for their pet. So this is just a brief slide that just kind of lists the things that I was commenting about before. So UCCR, low suspicion, not sick, low dose DEX, maybe high suspicion, you can do a low dose DEX or an ACTH stim. And then I have some of the comments about it on the side. ACTH, the fact that it's an unstable compound, but we have new technology, and that in the high dose DEX we can use to determine the difference between PADH and adrenal tumors. So we are going to do a little bit of case review. So we have let's see, I'm trying to move this because it's sort of in my way, but we have an 11-year-old female spayed. I can't see because it's sort of not, it's in my way a bit. But anyway, we have this 11-year-old female spayed miniature poodle and this is a low dose dexamethasone suppression test. And so low dose dex, so we are determining whether we have Cushing's or no. That's our question. At 0 hour, our baseline cortisol is 4.3. At 4 hours, we suppress to 2. And at 8 hours, we pop back up at 3.5. Now, an important thing to remember when I talk about suppression at 4 hours and escape at 8 hours, suppression is defined by either less than 1 or a drop of more than 50% from the baseline. So in this case, our 4 hour is 2, which is more than a 50% drop from 4.3. So that is considered suppression at 4 hours. And then up to 3.5 is our escape. So this animal has Cushing's disease. Does this result help us know whether or not it's adrenal or pituitary? The fact that there was suppression at 4 tells us this is most likely pituitary, because remember I said adrenal tumors do not suppress at all. Okay. Now we have a 10-year-old dog, and this is also a low-dose dex suppression test. Suzanne, I can't see part of the reading of what my description is at the top. So
Okay.
can you just read that to me real quick? It
Yeah,
just because I apologize, I can't remember what each of these are.
of course, absolutely happy to. This is for a 10-year-old FS Doodle with ALP 700 LDDST.
Okay, so this is a doodle with a high alk phos and a low-dose dex suppression test. So again, we're asking Cushing's not, okay? 0 hour is 2.5, 4 hour it suppresses to 0.5, and 8 hour it stays down at 0.4. So this is actually a normal low dose dex suppression, meaning this dog does not have hypercortisolism based on this test. Okay? The next one.
Okay, the next one. This is a 13-year-old Dachshund, PU/PD abnormal, low LDDST, HDDST.
Okay. So this is a dog that already we know this dog has hyperadrenocorticism, and we are trying to decide, do we have adrenal or pituitary? At 0 hour, it's 2.5. At 4 hour, it's zero point 0.5. And at 8 hour, it's zero point 0.4. So we already know the animal's cushingoid. Now we're asking, do we have adrenal or pituitary? And this is pituitary. It's a quote, normal HDDST test, but that means it's not adrenal. It could be, it's most likely pituitary.
Okay,
Next one.
this one is a 12-year-old Labrador with PU-PD and polyphagia, positive on the ACTH stem, HDDST.
So again, we have a positive ACTH stim. We know this Labrador has Cushing's disease, and we're trying to determine whether or not the dog has an adrenal tumor or a pituitary tumor. It's a large breed dog. We know that adrenal tumors occur more frequently in them. At 0 hour, we have 5. 4 hour, we drop to 4.5, and at 8 hour, we drop to 4. Because yes, we have dropped, but we've not dropped more than 50% of our baseline of 5. So this is considered positive for either an adrenal tumor or a pituitary tumor, most likely one of those pars intermedia tumors. This is a situation where you're probably going to have to image the dog's adrenals to verify whether or not there's actually a tumor on one of them. So this will require an additional step to differentiate, but it means it's more likely adrenal or one of those pars intermedia ones.
Okay, next
Next
one.
one.
Yep. Let's see. 15-year-old FS miniature schnauzer with PU/PD and ALP 690, ACTH stem.
Okay, so ACTH stim. So we've got an Alk Phos and a 15-year-old Schnauzer. Our 0 hour is 6.8 and our 1 hour is 9. This dog does not have a positive ACTH stim test. Positive is going to be above sort of 21, 22. That area between like 17 and 21, 22 is generally considered a gray area where it might be cushingoid, it might not. That's going to require you to take other information like what are the clinical signs? Is the alk phos elevated? Maybe imaging of the adrenal glands in that case. But this you can pretty much say will rule out ACT, will rule out Cushing's disease.
Okay, this
And
one
then
is,
lastly,
let's see, from 15-year-old Bichon mix with thin skin and ALP 980, also ACTH stem.
okay. So this one, our 0 hour is 6.8. Our 1 hour post is 20. So this is in the gray area, but it's getting up there. And we have a classic breed. We have an age. We have the thin skin. We have other clinical signs supporting it. This dog is most likely going to be cushingoid. I may consider looking at the adrenal glands by ultrasound and measuring them and seeing if they are plump and large. Both of them should be, most likely. So this is going to tell me my animal is cushingoid. You can get a similar stimulation with an adrenal tumor, though, remember. So this does not differentiate adrenal or pituitary. But I would consider this one strongly suspicious for Cushing's disease. Now, do you have to treat a dog for Cushing's disease who has this kind of a stim? If the dog did not have the thin skin or wasn't PUPD, I probably would hold off and maybe retest in a few months. Or I might consider looking at an ACTH level. So what do we do if we're not sure if it's an adrenal tumor or PDH and our high dose dex maybe was inconclusive or the ACTH stim and the low dose dex indicates Cushing's disease but your adrenal glands look normal. So you don't know if is the tumor just not big enough to see or why are the adrenal glands not plump if it's pituitary dependent? Or in some cases, just for fun, you have a mass on both adrenal glands. So one of them might be functional and one of them may be benign, or both may be benign. I have definitely seen all of these situations. Unfortunately, it's hard to tell whether an adrenal tumor is secreting cortisol without actually taking the tumor out. So, unless we do some of these testing. So, what are our options? Well, we could do an ACTH level. And this is where this could come in handy. So if it's high, then we think it's pituitary dependent. If it's low, it's adrenal dependent. So again, normally your hypothalamus secretes CRH, which tells the pituitary to secrete ACTH. And when we have an adrenal tumor, the adrenal tumor is producing cortisol, which reduces the ACTH production. And if we have an adrenal or pituitary tumor, you're going to get a lot of ACTH production. And that production is generally going to be constant. One caveat, if you have a pituitary macroadenoma, those cases tend to produce ACTH on a more pulsatile level, meaning they do not constantly produce ACTH. They will produce large amounts of it, but it may be more pulsatile, whereas the microadenomas tend to produce it constantly. So, like I mentioned, this is a very labile hormone. In this diagram, you can see that from 0 hour, the eACTH, the endogenous ACTH level, has dropped from over 40 picograms per mil to close to under 10 picograms per mil in just 24 hours, and actually even after 4 hours. So, it is not very helpful to have this be something you have to send out to a lab. But if you have a Truforma and you have the eACTH cartridges, you can run it in-house within 10 minutes and you don't have to worry about how labile it is. You don't have to package it. You don't have to do anything special with it. And you can also run a cortisol on this platform as well. So you can do all of your adrenal testing on this platform, all of your adrenal cortex testing. I'm going to say a brief thing about postprandial hypercortisolism. Um, some of you may have seen this. It's kind of a newly recognized phenomenon. There is a congenital misplacement of the GIP receptors on the adrenal cortex. GIP is a hormone that stimulates insulin production in the pancreas when this hormone is produced in the stomach with feeding. There have been occasional situations where GIP receptors will show up in the adrenal cortex of a dog where they're not really supposed to be. They're mainly supposed to be in the GI tract. And that animal will actually be stimulated to produce, or will be those GIPs will stimulate with eating, even on the adrenal glands, and it will tell the adrenal glands to produce cortisol. So you'll get these animals who, right after eating, suddenly get PUPD for a short period of time. It's very weird. They don't always have a lot of the other types of clinical signs of Cushing's disease. So if you have a patient that like gets PUPD or starts panting a lot after eating, and you test them and their adrenal function is normal, especially if they're fasted, you can try feeding them and doing a urine cortisol creatinine ratio and comparing it to a fasted UCCR. And you will see that cortisol creatinine ratio really go up after the animal is eaten. And we treat those with twice a day trilostane that's given with the meals. And usually we use a little bit lower dose of trilostane. I want to thank Pedro Armstrong for bringing this to my attention. There are one or two case reports of it, but I have had people call and ask me about it. So people have been talking about it. Okay, in the last short period of time we have, we're going to talk about hypocortisolism, which would be our Addison's disease. This is generally immune-mediated destruction of the adrenal cortex. That's the most common cause in dogs. It's the loss of cortisol response to stress and other stimulatory events like our ACTH being released. And we often lose loss of mineralocorticoid response as well. The classic hypocortisolism or hypoadrenocortisolism adrenocortisolism is where we have loss of cortisol and loss of mineralocorticoid. But we also know that in some situations we can have selective sparing of the zona glomerulosa of the adrenal cortex so that mineralocorticoid responses are still normal. So aldosterone is still produced, but cortisol is not. And that is an atypical hypoadrenocortisolism or hypocortisolism. So you only lose the cortisol. We used to think this is fairly rare, but we've started looking for it a lot more. And so it's important to think in dogs who have GI disease only, you need to be sure you keep atypical Cushing's disease on your diagnostic list. So in classic Addison's, there are likely a genetic component and to how their immune system works, and it's a fairly complex heritability. We do see it in standard poodles, Portuguese water dogs, Nova Scotia duck-tolling retrievers, soft-coated Wheatons, but really any animal can get, any dog can get it. And we also see it in cats occasionally too. If any of you remember, I'm pretty sure on almost every NAVLE exam or national board exam like back at what it was called when I took it. There was a black standard female poodle that was vomiting and had diarrhea and a low heart rate. And they all had Addison's disease. So some of you may actually remember that. Females are twice as likely to get this in male as males. The thought behind that is that females are also twice as likely to get immune-mediated disease than males. And 25 to 30% of them are atypical with only a cortisol deficiency. So hypoadrenal cortisol signs, in most of the cases, we're going to see lethargy, anorexia, vomiting, weakness, diarrhea. If you notice, the most common clinical signs we're seeing are associated with cortisol. All the GI signs are associated with lack of cortisol. Things like hypothermia, dehydration, weight loss, abdominal pain, polyuria, polydipsia, and the electrolyte abnormalities of hyperkalemia and hyponatremia, those are generally seen when mineralocorticoid is also missing. So it is a differential for a low cholesterol and a low albumin. So if you think you have a patient who looks like they have a protein losing enteropathy, that's an important differential to have on your list, other than IBD or GI lymphoma or lymphangiectasia. You also need to have atypical or typical Cushing's disease as well. This is a really important thing to think about. When we have a stress leukogram, the most reliable representative of a stress leukogram is a low lymphocyte count. Okay, it's lymphopenia. If you have a dog who has GI signs, maybe looks like a protein losing enteropathy, and you have cortisol lack on your list, if the animal has has a low lymphocyte count as well, and a stress leukogram, or even just a low lymphocyte count, the likelihood of them having cortisol deficiency is very low because you need to have cortisol in order to get that low lymphocyte count. If you have lack of a stress leukogram, meaning a normal lymphocyte count or a high lymphocyte count, that animal could potentially have Cushing or have cortisol lack. So that's an animal that you're going to have to do a baseline cortisol on to see whether or not it's above 2. If it's above 2, move on. It's not Addison's. If it's below 2, you're going to have to perform an ACTH stimulation test and see whether it stimulates or whether it's flat to tell you whether that animal has cortisol lack. So I mentioned the resting cortisol less than 2, plus lethargy and anorexia, plus low sodium and low albumin, high suspicion for hypoadrenal. In about 34% of the cases, we also get hypercalcemia. It is one of our differentials for that. We see that most commonly when there's mineralocorticoid missing, not just cortisol. So again, our ACTH stimulation test, you need to have corsentropin for it. What we're looking for is 1 hour post-administration of the corsentropin. We're looking at that cortisol level, and we're looking to see whether it goes up above 2 or whether it stays flat. Um, Treatment for a stable patient with hypocortisolism um, is fairly straightforward. We supplement what they're missing. In a crisis patient, this is when we have the benefit of using the in-house cortisol testing because you can find out right away what your cortisol level is. Especially on a weekend when our lab does not run a cortisol level and I would have pickup from outside labs, and it will take me 24 hours to get my test results back. Sorry, that was Wally reading his father. Um, the cortisol level you can get back within 15 minutes, and you know whether or not this crisis patient has hypocortisolism and how you're going to need to treat it. Okay. Even if you don't have the ability to run a cortisol in-house, you're still going to treat these patients with IV fluids, which is the best treatment regardless because they may come back in shock. They may, you're going to treat them with fluids when they have significant GI disease, where they're dehydrated, hypotensive. Again, you're going to use fluids. So you can treat them with IV fluids until you get your test results back 24 to 48 hours later, if you're unsure and you don't have the ability to test in-house. So that is an important thing to remember. If you have a stable patient, you're going to replace what's missing. You're going to give them zero point 0.1 to 0.25 mg per kg per day of prednisone or a pred equivalent steroid. You're going to tailor the dose to the patient so that their GI signs go away, but they don't have polyuria and polydipsia. And if they have stressful events, the owners give them an extra dose of the meds. If they need mineralocorticoid supplementation, we usually use either DOCP at 2.2 mg per kg or even a lower dose at 1.5 mg per kg once a month, and then we adjust it as needed. And then we can also use oral daily fludrocortisone, which also has a little bit of cortisol effect as well as the mineralocorticoid. And we adjust about every 5 days based on their electrolytes. If you have an animal in Addisonian crisis, you're going to treat them for hypothalamic shock with IV fluids, either crystalloid or hypertonic saline if they're hypotensive. You're going to give them steroid support once stable. Draw your samples for your ACTH stim if you can before you give them any steroid. But if they are really unstable, give them DexSP at 0.1 mg per kg IV. That is equivalent of about a mg per kg of prednisone, and dexamethasone is less highly detected on cortisol tests than prednisone is. So you may still be able to get a good result with your cortisol test, even if you already had to give them a dose of Dex. And if they're hyperkalemic to the point where their heart rate is dropping, or you're worried about ECG abnormalities that you see with hyperkalemia, you could also treat them with that. Fluids alone are probably going to do the job, though. These dogs have a lot of pre-renal azotemia oftentimes. Fluid's going to drop their BUN and creatinine, and it'll drop their potassium too. They may need GI support because remember, the gut is the shock organ in dogs. And we always have to remember if a dog comes in shock for whatever reason, they may develop pancreatitis post-shock a couple days later. Then, when they are stable and you're comfortable with your diagnosis because of your test results, you can start DOCP or Florinef and then transition to oral steroids from the IV DexSP.